Okay, so.
Hi guys. Sorry again for the late start. I'm Rebecca, so I'm going to take you through stroke and TIA, and then Hannah is going to come talk to you about kidneys. So just to give you a feel for what we're going to go through, we'll just basically cover what stroke and TIA is, the very basics of epidemiology and aetiology. We're not going to go into much detail there. Then we'll talk about some of the symptoms patients come in with and how you correlate that to the area of the brain that's been affected by the stroke. Then we'll go through how you assess the patient, and finally how you manage the patient. So one of the most important things to know about stroke is that it's a clinical diagnosis. So particularly if you're ever speaking to a stroke consultant, don't say they've had a stroke because the CT says so, because they will not be happy. Sometimes in exams, they quite like you to come up with the definition. I'm not Leeds trained, so if I tell you something that you don't think you need to know, you're probably right. A stroke is a focal, non-convulsive neurological deficit of vascular origin with symptoms that last over 24 hours. And a TIA, transient ischemic attack, is a focal, non-convulsive neurological deficit that lasts less than 24 hours and has complete clinical recovery. The most common presentation for stroke is hemiplegia, and if you see hemiplegia in an exam question, it should certainly make you think about stroke. About 85% of strokes are ischemic, and the rest are hemorrhagic. And of the hemorrhagic strokes, the most common cause is chronic hypertension, and that's because it causes microaneurysms called Charcot-Bouchard aneurysms that then rupture. If you have a patient who's had a stroke in the last few days or weeks, lots of ischemic strokes go on to become hemorrhagic. So if you see a deterioration, always think about that. TIAs, symptoms come on really suddenly, and they're at their worst within 1 minute. They're often recurrent, and patients will often recognise them themselves because they've had them before and they get the same symptoms each time. And the symptoms are caused by hypoperfusion in the brain, so when an artery isn't fully open but partially stenosed and there's not enough oxygen getting there, but it does get there in the end. One of the really important things about TIA is that a large number of them will go on to have a stroke, and the risk is highest in the days and weeks following a TIA. So it's really important to recognise these patients, refer them appropriately, and manage them to prevent a stroke. I don't think you need to know much epidemiology, but you should know that it's the commonest cause of adult disability, and it does account for 12% of all deaths, so it's a huge topic. And as you go up your careers, it'll become increasingly important to you that it accounts for 5% of the NHS budget. If you need to know the incidence figures, they're there. Don't focus too much on them. The main point is that as people get older, the chances of them having a stroke increases a lot. A general rule of thumb, when someone's asking you about prognosis, is that a third of patients will die. A third of patients will recover really well and go back to independent living, and a third of patients will have some residual disability. As you can see, about 10% of patients die in the first week, and that mortality continues. And if you go beyond the first year and look to 5 years, the mortality cumulatively keeps going up. Things that should raise your suspicions that this patient might not do well: if they've gone into a coma, that might be because they've comed already, so that could be very bad. If you get a conjugate gaze defect, so the patient is having trouble moving both their eyes in the same direction at the same time, with a hemiplegia, it's not definitive, but it's indicative of a total anterior circulation infarct, so they tend not to do very well either. And if you've got really severe hemiplegia, they don't do particularly well. If somebody has a hemorrhagic stroke and they've come in with a really bad initial presentation, they're more likely to die initially, but if they make it through that, they do tend to do better long term. common causes of stroke are listed here. It's quite important to know the risk factors for stroke, because you need to know them when you're taking your history, because you need to ask about them. You need to know about them when you're making your treatment plans, because you need to modify them. And they might come up in written papers as well. I was always taught the mnemonic HALTs, which are the 5 big modifiable risk factors. So the H stands for hypertension, so you should aim to control the blood pressure. The A is a bit of a tenuous one. I use it for cardiac because it stands for all kinds of things: AF, arrhythmias, coronary artery disease. The L stands for lipids, the T for tobacco, and the S for sugar, so diabetes. Other things that increase your risk are homocysteine, which tends to be genetic and there's not great evidence that doing anything about it changes things. Family history, you obviously can't modify that, but it's important to ask about it. Obesity and diet, that you can do something about. And if you see a young woman, always ask if they're on the oral contraceptive pill. So I'm mainly going to be talking about ischemic strokes, but hemorrhagic strokes account for about 25%. And they can be due to hypertension, as we've already said, small vessel disease, aneurysms, arteriovenous malformations, and all kinds of other causes. And as we've already said, the hypertension causes strokes because it leads to these tiny aneurysms that are mainly found in the internal capsule of the basal ganglia, and they rupture. You can get hemorrhagic stroke in any part of the brain, though, and it's very difficult to distinguish using clinical symptoms from an ischemic stroke. But if you see a mass effect, which is something you see on CT, so if you see a midline shift, or if you see a patient whose consciousness is dropping, that should make you think of a hemorrhagic stroke. Otherwise, it's really hard to tell. So now we're going to talk a little bit about the anatomy and what symptoms patients come in with and how you put the two together. So you don't need to know this diagram, but the point of it is that you've got an anterior circulation that comes from the carotids, and that goes into the circle of Willis and gives you the middle cerebral artery and the anterior cerebral artery. And your posterior circulation is formed of your 2 vertebral arteries that go up the back of the neck, join to form the basilar artery, which runs over the pons, and that gives you your posterior cerebral arteries. And here you've got it shown from the circle of Willis perspective. And this is just a nice diagram that shows you which parts of the brain are supplied by which arteries. The main point to take away from this slide is notice how much of the brain is supplied by the MCA. It's by far the most important artery in stroke. So the middle cerebral artery, it's not just the commonest artery involved in stroke, but it also often causes the severest defects. It's the largest branch of the internal carotid, and as we've already seen, supplies huge areas of the brain. You find Wernicke's and Broca's area in the dominant side of the brain. And remember, in pretty much all right-handed people and most left-handed people, this will be the left-hand side of the brain. Whereas in everyone else, well, in the few lefties, it's the right-hand side. If you get a lesion in the non-dominant side, you get visual spatial problems. So that's things like inattention, difficulty dressing, neglect of a limb. And so what does an MCA stroke cause? Well, it causes hemiplegia on the opposite side, to the side of the brain affected, hemisensory loss on the opposite side, a homonymous hemianopia, and I've got a slide about that for those of you who've forgotten what that means. If you get a stroke on the dominant side, as we've already said, you get aphasia because Wernicke's and Broca's are affected, and if you get it on the non-dominant side, you get visuospatial problems. For those of you like it in pictorial form, that pretty much says the same thing. Now, what I want you to notice here is you hear a lot about total and partial anterior circulation infarcts. If it's a total anterior circulation infarct, you need all 3 of the things that are inside that red circle, plus one other thing that suggests that you've got a problem with your higher cognition. So it could be any of those things outside the circle or a decrease in consciousness. If you don't have all of that, it's partial, and it's as simple as that. So homonymous hemianopia, it's a bit of a mouthful, but if you look at number 7, if you get a lesion on the right-hand side of your brain, it means you can't see on the left on either side. And in MCA strokes, that's because it affects the visual pathways as they go through the temporal lobe. The anterior cerebral artery is much less important. You very rarely see pure ACA strokes. You don't need to know much about it at all. What is quite a nice thing to know is that they're joined by the anterior communicating artery, and that acts as collateral circulation. So if you get a proximal occlusion, you don't really get any problems, but if you get a distal occlusion, you get the problems that are noted here. And it mainly supplies the legs and the bladder, so that's mainly where you get problems. And if you see primitive reflexes, that tends to be anterior cerebral artery as well. Lacunar strokes, they are 25% of ischemic strokes. And that means it's where you get an infarction in your internal capsule. And so you might get an isolated hemiparesis with no other symptoms, an isolated hemisensory loss with no other symptoms, ataxic hemiparesis, which just means you're a bit weak and wobbly in an arm or a leg. Or you might get clumsy hand dysarthria syndrome. It's exactly what it says on the tin, a clumsy hand and some dysarthria. The ophthalmic artery, you don't need to know about at all, but just recognise in TIA, you sometimes see people come in with sudden painless visual loss, and they describe it often as curtains being drawn over the eye, and that's very classical of a TIA affecting the ophthalmic artery. Now we're on to the posterior circulation. Main artery in the posterior circulation is the posterior cerebral artery, and they come off, that's formed by the basilar artery as we saw earlier, and sends branches to the lobes that are listed on the slide. Now, you're most likely to see an MCA stroke in an exam, but if you see something a bit weird that doesn't really make sense, think about the posterior cerebral artery. So if you've got a homonymous hemianopia but the macula's spared, that's the posterior. If you've got complete visual loss but the patient tells you they can see fine, again, it's a bit weird, it's posterior artery. If you've got hemiplegia on one side, which might make you think MCA, but you've got a third nerve palsy on the other side, again, it's a bit weird, and that's the posterior cerebral artery. This slide, don't let it terrify you. No one expects you to know the cerebellar arteries in much detail, but they do come up in exams sometimes because they divide up quite nicely into about 4 different arteries. The only one anybody expects medical students to know about is PICA, the posterior inferior cerebellar artery. So if you see a question about cerebellar arteries, don't even bother reading it, just pick posterior inferior. That's all you need to know. And locked-in syndrome, really unlikely to come up in your exams, but you're all going to be physicians, and just beware of the patient who looks like they've had a brainstem death, but they're still moving their eyes. So, what do you do if you think someone's had a stroke? Always in exams, you start off with a history and examination. So on the history, what are you asking about? You're asking, how did it start? How did the symptoms come on? Did you have a TIA beforehand? What symptoms do they have? Do they have a headache? Headache does not mean you have a stroke. If someone comes to you with a headache, they don't have a stroke. However, if you think someone has a stroke and they also have a headache, that might push you more towards a hemorrhagic stroke. Are they becoming more unconscious? Are you getting this history from a family member? That's pretty serious. You should probably do something about that. Call a senior. Always ask about risk factors. They love risk factors in exams. And in the path medical history, remember to ask about TIAs, strokes before, and you can ask for the weird and wonderful if it's a younger patient. In the drug history, always ask what anticoagulation they're on. Are they already taking aspirin? And if it's a young female, ask if they're on the oral contraceptive pill. And one of the main things in stroke histories is to ask what were they like before this happened? Were they independent at home? Were they in a wheelchair and completely dependent? So always ask about their activities of daily living. On examination, you're probably just going to be doing a neural exam in an OSCE. But once you hit the wards, some things you might want to look out for if you want to look a bit clever. Look for causes of the stroke, so look for emboli, so feel the pulse for AF, listen over the carotids for bruits, look for signs of endocarditis. Do they have high blood pressure? Main cause of hemorrhagic stroke. Stenosis, blood pressures in both arms. Again, that's for causes. Now, do they have pneumonia? That's a bit of a weird one. Sepsis can be quite a good stroke mimic. So it could be sepsis instead of a stroke. Also, if they already have a stroke, swallowing problems, they're really likely to develop pneumonia, and that's going to make them worse, and that's something you might be able to improve. And then from the neuro side of things, in an exam you're just going to be doing, cranial nerves or a limb exam, but at the end it's quite nice to say, I would also like to assess this patient's GCS and perform a swallow assessment. If you want to come up with a differential diagnosis, this is the kind of thing you might be expected to come up with, and vary it slightly depending on what symptoms they have. But obviously, if they don't have any seizure, if it doesn't sound at all like a seizure, don't just reel off seizure. But that's pretty much what I'd expect you to come up with. And this will all be on the website for anyone who's struggling to scribble it down. Now, how would you investigate it? Basic investigations doesn't mean these are really simple things everybody should think of. It means this is what we do before we get to fancy things like imaging. So, and it's always nice to know why you're doing something. So, why are you taking a full blood count? Well, polycythemia is a risk factor for stroke. Infection might make it worse, or it might be a consequence of the stroke. And raised ESR or CRP might push you towards inflammatory disease. Look for signs of diabetes. Check the cholesterol. A blood culture. Endocarditis might have caused emboli that caused the stroke, or they might have superadded infection. In a younger patient, think about weird stuff like autoantibodies. Coagulation studies can be quite nice, especially if you're going to thrombolize somebody. ECGs and echoes, if you think they need it, which most stroke patients do. And a chest x-ray, everyone who comes through an acute admissions ward gets a chest x-ray and an ECG, at least they should. And then you go on to imaging, and all stroke patients should have a CT scan within 24 hours so you can work out whether it's ischemic or hemorrhagic. The reasons you might need an MRI are if you think you've got a posterior stroke on your hands, there's lots of bony artifact that makes those areas of the brain hard to see on CT, so you might get an MRI in that case. Or if you get a CT that comes back clean, you might go to an MRI because you think it was just too small to show up. And really the basic rule of thumb is just get whatever's faster. So if you're in a really high-tech neurosurgical hospital, it might actually be easier to get an MRI out of hours than a CT. You don't need to know this. This is just for those of you that are interested. Just be aware that if you want to look at the internal carotids and other blood vessels, carotid Doppler is a nice, non-invasive way of looking at the neck. CT angiography and MR angiography, so you go through the scanner with a bit of contrast through a peripheral cannula. That's a nice way of looking inside the head. And you can still do angiography with contrast and x-rays, and you do see that sometimes. So how do you...
Sorry, the investigations before, were they just for stroke, or...
Which ones?
The basic investigations, or were they...
This is specifically for stroke, and, well, TIA you do the same thing, because you're worried that your patient's going to have a stroke within a few days or weeks. So, I mean, if you have a TIA, you wouldn't necessarily jump to a blood culture, and you wouldn't necessarily do a blood culture in a stroke patient, but if you think there's a chance they might have sepsis, you'd absolutely do it. So, everybody doesn't need all of these. For instance, the autoantibodies you'd only do in a young patient, but these are the kind of things you should think about. Definitely in stroke and probably in TIA. So, we're going to go through the management of a stroke and then we'll go through management of a TIA, and they're very similar really. So first off, make sure it is a stroke before you start going down this line. And the first thing to do is get them admitted to a hyperacute stroke unit, because there's lots of evidence that shows that patients do a lot better. Now, if it's an ischemic stroke, one of the first things they do is reopen the artery, and that's thrombolysis. They can only do that within 4.5 hours. After that, you don't get it. And they can only do it in certain places, so the stroke unit will be able to do it, and in some areas A&Es can do it, but not everywhere. And it's worth having a look in the Oxford Handbook at thrombolysis and going through the contraindications for yourself. A few months ago, I was shown a picture by one of the stroke consultants of a young woman who'd had a horrific stroke, and he wanted to show me the CT scan because it's really bad. And when we were putting up the images, it happened a few weeks earlier. The first thing we saw on the PAC system was an ultrasound, fetal ultrasound. And so he'd made the decision to go ahead and thrombolize, and she'd been pregnant at the time. And it's probably the right decision because it saved her life, but it's always a bit of risks and benefits. Once you decide whether or not you're going to thrombolize, you want to prevent early recurrence. So everyone should get aspirin 300 milligrams, and that's stroke and TIAs. Don't give heparin for the first 2 weeks unless there's a really good reason to. So if someone's in AF, you might think about it. Otherwise, you tend to avoid it because it can make things a lot worse. Hemorrhagic strokes, for obvious reasons. And remember I said ischemic strokes, lots of them go on to become hemorrhagic. And if someone has comorbidities where you don't want to give aspirin, clopidogrel. And then you go on to protect them from secondary brain damage. So maintain physiology, make sure their blood pressure is reasonable, it's not too high, it's not too low, all the basic stuff. And treat complications as they come up. And don't be scared of referring to neurosurgeons if you think someone's got edema, because they need they need their skull to come off to release the pressure. These are some of the complications that you might see. Cerebral edema is certainly one to be aware of, and I think I've got a slide coming up on that. Completion of strokes, it can keep getting worse before it gets better. It can happen again, that's a big one, and it can become hemorrhagic. And always remember you might have the wrong diagnosis. But you don't need to worry too much about that. Maybe learn one or two from this side of the list, but the things you should be able to reel off are what are the complications: infection, hypoxia, hypercapnia. These things are very common. So herniation and edema, these are probably the most serious complications of stroke. And they happen mainly in large MCA infarcts that are called malignant because they're just that bad. So if you've got this, you get severe hemispheric stroke syndrome. So you've got hemiplegia, your eyes and your head are deviated, and you're really deteriorating in those first few days. The CT shows signs of an infarct really quickly, and there's an 80% mortality with this. You don't need to know what's on the bottom of the slide, it's just for those of you who are interested. Steroids aren't very helpful. Mantle's not very helpful, they might have some. Really, you need to get that skull off and relieve the pressure. So once someone's gone through stroke and they've got to the end, you're thinking about discharging them. What do you need to do then? Well, make sure they don't get complications, manage their swallow appropriately, things like that. Think about rehabilitation, can you get them better than they are? And then we've got Holt's again, so hypertension, anticoagulation, so that's for all your cardiac factors, your lipids, smoking and tobacco, and your sugars. If there's an embolic source, treat it. If they're on things that are making it worse, treat it. If they're on drugs that are making things worse, stop them. So if someone has stenosis of their internal carotid, sometimes they do endarterectomies, and often in stroke patients you see little scars here, and that's quite a nice sign to pick up in an exam. The surgeons know what they're doing, so they do try and make the scars subtle. But the reasons you don't do it in everyone are because it can actually cause stroke, because you're playing around and you might dislodge some of that plaque. So it can cause cranial nerve palsies, it can cause cardiac events. You've got a neck incision, so you're going to have a scar, you could get a hematoma, not to mention it costs the NHS money, and it costs patients quite inconvenience coming in for a procedure. So to have this, you need to have more than 70% stenosis of the correct internal carotid artery of the symptoms. If you have 50 to 69%, you can think about it depending on other factors, but if you have less than 50%, there's no way you're getting in. So that's stroke. TIA. Again, the first thing you should do is confirm the diagnosis. And then the next thing to do is work out how fast do I need to act with this patient. So some patients you need to send to A&E on the spot. And those are patients who have symptoms when they're sitting in their GP practice. They need to get an ambulance and go. If they have an ABCD2 score of 4 or more, within 7, or they had symptoms in 7 days, they need to go. And I'll show you that score in a minute. If they're in AF, they need to go. And if they're having multiple TIAs, then they need to go as well. All other patients get referred to a rapid access TIA clinic and will be seen within a few days, but they don't need to be seen, within half an hour. This is the ABCD2 score for those of you who want to learn it. Really, just look that it stands for age, blood pressure, clinical features, duration of symptoms, and diabetes. And a score of 4 or more needs to go to A&E. So, once you've worked that out and you're trying to sort them out, treat the risk factors. Either give them aspirin with dipyridamole or give them clopidogrel on its own. Again, don't anticoagulate them in the first 2 weeks unless there's a really good need for it. and investigate possible things that might be causing this, like stenosis of your internal carotid.
How long do you give the aspirin? Is the aspirin for life? And well,
They'll be on aspirin for life.
is it 75 milligrams?
No, if you see a TIA or a stroke, start with 300 milligrams of aspirin, and then normally a consultant will make the decision to step that down a bit, but it tends to be for at least a week or two they're on 300 milligrams. But for life they'll be on 75 milligrams. And you can look at lots of papers about is aspirin and dipyridamol better or is clopidogrel on its own better. And really some patients respond to one and some patients respond to another and you don't really know. So you try them on one. If they're bleeding, you stop and give them the other. If they're having recurrent strokes or TIAs, you stop and give them the other one. And just see if they do any better on that.
What happens if they have AF and they're already on warfarin? Would you then add the clopidogrel into it? Because then they'll be on warfarin and
If they're already on warfarin, I get a consultant involved really early on because they could still have a hemorrhagic stroke, in which case you want to stop and reverse that warfarin. And if they have an ischemic stroke, you might still think about stopping it, and you might even consider reversing it if you think they're going to transform hemorrhagically. It's not a decision I would make as an FRM. Driving, it's nice to mention this in exams, and you should know it when you're an F1. Any patient who's had a stroke or a TIA, they shouldn't drive within a month. At the end of that month, if they don't have any residual disability, they can just start driving again. If they've had lots of TIAs in a short time, they should have at least 3 months off. And in terms of preventing this from happening, primary prevention is stopping someone who's never had a stroke from having one in the first place. And second prevention is your patient in hospital with stroke. You want to make sure they don't go on to have a second one. And you do the same things for both. Things you can do to the lifestyle are encourage them to be more active and get their weight down, go on a healthy diet, so reduce salt, reduce sugar, reduce saturated fat. And it may be no fun, but cutting out smoking and alcohol helps. Medically, you want to get that blood pressure below 130/80. Again, clopidogrel or aspirin and dipyridamol. And really, if you want to remember one thing, that's the thing to remember. Start statins. Long term after the acute event, start warfarin for anyone who's in AF. But again, only 2 weeks after the event. And glycemic control for people with diabetes. So, stroke is a clinical diagnosis. It's the commonest cause of disability in the UK. Remember that a third die, a third recover, and a third remain disabled. Recognise it and get them to an hyperacute stroke unit. Give them high-dose aspirin, dipyridamol, or clopidogrel on its own. You can only thrombolyse ischemic strokes within 4.5 hours. The mainstay of treating it is modifying the risk factors. And if someone's had a TIA, then they're at most risk of a stroke in the first days and weeks. And refer them straight to A&E for high risk. Everyone else should be seen in rapid access clinic. These are some references if anyone wants to read more, but I'm sure you know where to look for yourselves. Has anyone got any questions? Yeah?
You might have answered this,